This is a mini lecture on spinal cord injury and peripheral nerve problems. I'm going to start this lecture with the spinal cord injury section of the chapter and then hope to upload a second video for the peripheral nerve problems that the book talks about, which is just a few. The information we talk about in the spinal cord injury section, we will then apply that information in class to an unfolding type of case study. So the book starts by talking about some statistics about spinal cord injury, the causes specifically of spinal cord injury. You can see motor vehicle accident topping that list, and that can vary depending on where that patient lives. There are special concerns when we think about our geriatric patients because they are dealing with other disease processes. So adding a spinal cord injury on top of that complicates a recovery with spinal cord injury. When we talk about a spinal cord injury, it's broken down into primary and secondary. That primary injury basically means the brunt of the injury of the spinal cord injury. So it's bone displacement, it's interruption of blood flow to that cord, the neurological damage that can occur. So it's that initial brunt injury. Then you have the secondary injury, and this is ongoing and progressive, and it happens because of the healing process that the body is trying to help out with. So in comes rushing blood, metabolites, norepinephrine, dopamine, serotonin. Everything comes rushing in to try to help. Well, with that, if you think about a straw or a tiny tube, you think about a straw, a bigger straw, let's say, there's not a lot of room in there, right? So it's kind of our spinal column. It's not real big. So if you add in a bunch of blood and metabolites and everything that comes to that primary injury site, we could have a lot of swelling and a lot of edema that's going to happen from that. And in turn, that injury is going to look more severe than maybe it actually ends up being, because that cord is being compressed from all of the fluid rushing in to heal. So your book will say in 24 hours permanent damage occurs because of edema. You can't determine the exact extent of the injury up for a week. I'm going to say maybe even longer. It could be up to 2-3 weeks. It just depends patient to patient. And we're going to talk about that in class of how that looks from person to person. It is really important, though, if you think about that initial care and management is obviously very crucial. So if that spinal cord injury isn't dealt with in the appropriate manner and in a timely manner, that cord is going to continue to be compressed because of that secondary injury, and the long-term effects of damage is going to be worse. So obviously time is key here. Hypoxia is going to happen because of all of the issues that are going on within that spinal cord, and the substances that are released, they cause vasospasms and leads to hypoxia and long-term necrosis in that area of the spinal cord. Book then talks about spinal and neurogenic shock, so there are some differences here in that. These are temporary syndromes that occur after spinal cord injury. The first being spinal shock. With spinal shock, we have decreased reflexes. We have loss of sensation and flaccid paralysis below the level of injury, as the slide says there. It can last from days to weeks, and a patient can have rehab during this time. But an important thing to note is once this spinal shock is resolved, the opposite happens. A patient has a very hyperactive spastic responses, and that can be very painful for patients. So spinal shock itself, we have decreased reflex, we have loss of sensation. But in recovery, when we know that they have recovered from this, we have hyperactive spastic movements that can happen. Okay? This can happen in 50% of patients with spinal cord injuries. 50% of those patients can experience spinal shock. Some things that might be given for this patient might be baclofen, which is a muscle relaxer that could help them with the spasticity that happens after the resolution of spinal shock. And then neurogenic shock. It's associated typically with cervical or high thoracic injuries, usually T6 or higher. And it's going to include hypotension, bradycardia, because what's happening is the body in shock is dilating. Okay, so we're having vasodilation, and in turn, if we're going to vasodilate, we have a decreased cardiac output. This is happening because of the loss of the sympathetic nervous system innervations. I'm going to tell you a story about what this looks like with somebody in neurogenic shock when we're in class. But there is an interruption in that sympathetic nervous system, and the body's unable to regulate itself like it normally would. So we have that vasodilation, the blood pressure is going to go down, and they have severe bradycardia, and a patient can die from this. So it is very significant. They do also have loss of vasomotor tone. Blood starts to pool because of that vasodilation. And again, it's going to reduce venous return of blood to that heart, which is going to in turn decrease cardiac output. There are classifications of spinal cord injuries. So the mechanism, and your book does show you pictures of that. So there are flexion, hyperextension, flexion, rotation, etc. You can read that there. A common one that we hear about is compression fracture. That is somebody like who's dove into a pool that's too shallow. Motor vehicle accident, a lot of times we see flexion injury from that, hitting the steering wheel in a motor vehicle accident. Then there is a level of injury, and that's a skeletal level of injury. So is it a cervical? Is it thoracic? Is it lumbar? So you'll hear somebody say, I had a C6 spinal cord injury. So it's the cervical and the 6th spinal column. So that is the level. And then degree is complete or incomplete. Complete meaning the cord has been severed. Incomplete, there are still some communication and some tracks intact in that column, so which allows that communication somewhat within the spinal column. With somebody with a complete spinal cord sever, there is not a chance for that to come back and regenerate its neurological cells. In somebody with an incomplete, the neurological system is pretty amazing, and it can regenerate, and over time things can start to heal. So if somebody has a cervical injury, typically they're paralyzed all 4 extremities, and that we call tetraplegia. Commonly, we probably have heard in the past as a quadriplegic. New terminology for that is tetraplegia. If the damage is low in that cervical area, there is a chance that the arms might not be completely paralyzed, okay, especially as time goes on and with rehab. But anything, the higher you go with that cervical injury, they are going to be tetraplegic. Thoracic and lumbar injuries, paraplegic. So they just have their lower extremities, waist down, typically, that are affected, and they're able to move their arms and hands and such. This is just another chart or another slide on the complete versus incomplete. You can read through that. And then your book talks about syndromes that are associated with incomplete lesions. You can look through that in your book and read through it, have an idea of what those things mean, but do you have to memorize them word for word and know exactly what each one means? No. Will you come across some questions maybe in your EAQ that talk about that? Absolutely. This I see as, think about your nurse that's learning about, or in second semester when you guys learned about patients with cancer. We didn't learn about every single chemotherapy drug, because unless you're going to work in a cancer treatment center or give chemo every day, you're not going to really come across that and need to know that. This is how I kind of feel about these incomplete injury syndromes. You don't hear people talk about these. Now, if you worked in a spinal cord injury facility, you're absolutely going to know those. So, for purposes of testing and for purposes of being a entry-level new grad, be familiar of the names of these and that they exist if you want to kind of read through and kind of have an idea of what they mean, but to memorize that word for word and know them inside and out, I wouldn't spend very much time on that. Here's a breakdown of the paraplegia and quadriplegia. Again, that quadriplegia updated name is tetraplegia. Paraplegics, the thoracic and lumbar we said, and then quadriplegia, the C1 through C7. There are many clinical manifestations, many different body systems that are affected when somebody has a spinal cord injury. Your book has a really nice chart in it this edition of Lewis happens to be in 1423, I would definitely get to know that table very, very well. It is really important that you guys understand what a cervical injury looks like, a high cervical injury compared to a middle, or a lower cervical injury compared to a thoracic injury and lower. So really spend some time on that table, really get to know it, and again, we're going to talk about that more in class. And then we're also going to, in class, talk about the different effects. So if you'd like to read through that, it's really pretty easy information to read about. Some highlights to get you thinking before class. In the cardiovascular system, any injury that is above T6 will cause dysfunction in that sympathetic nervous system, which amounts to leading to bradycardia. And we really have to think about that if we are suctioning somebody or doing something to that patient that could trigger the vagal response. All right, so if you're suctioning somebody with a spinal cord injury, let's say they have a trach or they have an ET tube, if that suctioning itself would trigger the vagal response in somebody that has a spinal cord injury in, let's say, C8, they could become very bradycardic and have a significant response from that would be detrimental. So we have to really watch their vitals closely. Some in the GI system, we can have paralytic ileus and hypomotility in patients with spinal cord injuries, especially to the area of T5 and above. Pain is a huge factor in patients with spinal cord injury, especially early on in their injury. And this can be very neurogenic pain that they're dealing with. A lot of times patients are given Neurontin to deal with this because literally looking at a crack in a sidewalk when they're in their wheelchair can potentiate that pain by just anticipating that. So it can be very, pain can be a significant factor that patients are dealing with, including burning, tingling, pins and needles, cold, shooting pain. So all of these things basically are neuropathic in nature. At the top of the slide, I forgot to mention the ASIA scale. Your book does break that down a little bit. It's a way to classify an injury, especially you'll mainly hear that in patients that are rehabbing with spinal cord injury, and it gives them an indication of what their recovery might look like in the future. So you can see if you look at that ASIA scale, it breaks it down into A, B, C, D, E, or not determined. Diagnostic studies, if somebody comes in with a spinal cord injury, they're going to first run them through the CT scan just to get an idea of what things look like with their injury, and then they might need to do an MRI to further assist in that diagnostic process. Obviously, your book then talks a little bit about a Doppler duplex ultrasound, and that we hear most commonly with diagnosing what? Think about, when are we going to do a venous Doppler? I'm trying to rule out a DVT, right? Why would somebody with a spinal cord injury, why would they even put that in this chapter? Very common, right? They're not as mobile as before, so they're sitting more. They're at great risk for developing clots. So that's why that's mentioned in that diagnostic study part of it, that venous Doppler, they call it a duplex Doppler. Some surgical therapies that are discussed. If this patient has a spinal cord injury, especially with a motor vehicle injury cause, more than likely there's more than just spinal cord injury damage. In the case study we're going to talk about in class, there's multiple damage to this patient. And so it really was a big decision on when they went to fix the spinal cord injury, first, when they were going to fix it, and secondly, how, because of all the other internal injuries from this patient's initial cause of spinal cord injury. So anterior approach or posterior approach, obviously anterior from the front side. Again, it just depends on the other internal injuries that are going on, and really it depends on the surgeon's preference as to what they think is going to be the best response from this type of surgery. Sometimes both approaches are needed. And this is basically to clean up that bony fragments that are sitting in that spinal column from the injury. Drug therapy, your book will talk about. Salumedrol is no longer approved by the FDA for spinal cord injury use. Do we see that in other treatments? Absolutely. Our COPD patients we use all the time with Salumedrol. The reason why it's not approved anymore for spinal cord injury use is because it wasn't just a little bitty dose of like 40 milligrams of Salumedrol. We're talking a big, huge dose of Salumedrol. Obviously, think about why would we give that in a spinal cord injury patient. Think about that primary injury, think about the secondary injury, and how crucial we said it was to decrease that swelling. So, giving that Salumedrol, the thought process behind that was to decrease that inflammation, the quicker the better, so that we would have better long-term goals in these patients, less necrosis within that spinal cord itself. But, like I said, the FDA no longer approves that. Your book goes by that. I honestly haven't talked to other facilities around here to see if they still use it. The risks of using it can cause a GI bleed. It leaves them more open to infections and things of that nature. I'd be curious, like I said, though, to ask places, let's say like in the city, the big hospitals that take care of spinal cord injury patients, if they do, what their thoughts are on that. Vasopressors are used in spinal cord injury patients. It really highlights that norepinephrine and levophed. The goal really is to keep that patient's MAP above a certain number. We would actually like to see that MAP greater than 85 to 90. Okay. So obviously watching your patient with a spinal cord injuries, initial and ongoing actually, vital signs is crucial. And obviously if you're administering these drugs in an ICU setting, that's going to be crucial. There is a chart in your book. In this edition, in the 10th edition, it's on page 1425 of emergency management. I would also read through that. And here you'll see they talk about the MAP. It's really important to make sure their SaO2 is greater than 90%. It'll show you different interventions and talk about assessment findings, so I definitely take time to read through that. Your book goes on to talk about immobilization methods in somebody with a spinal cord injury. So you can have somebody in skeletal traction. They might have a halo. Okay, they might be in cervical traction, and it's going to be important to note how to care for these patients. So these patients actually have, you can see the picture in your book, they actually have areas that you're going to have to care for on the skin to prevent infection. So the nurse would be responsible then for cleaning these pin sites, depending on the hospital policy. Your book talks about commonly using half-strength peroxide with normal saline and then applying an antibiotic ointment. So assessment of these areas would be crucial. Obviously, receiving an initial spinal cord injury patient to the emergency room setting, how are they going to have those patients immobilized? C-collar, right? They're going to have them on a backboard. They're probably going to have their head taped to that backboard. They're going to make sure that when we're moving this patient, both in that initial setting and ongoing as needed, in a log roll position, because we want to keep that spinal column as neutral as possible. As that patient gets more mobile in their recovery process, in someone with skeletal traction, they might have the halo vest, where they can actually be more mobile and be able to, depending on their level of injury, sit up and move and transfer bed to chair, etc. And then a TLSO, you'll hear this not just in a spinal cord injury, but any patients that have any orthopedic issues that you might hear them fit for this brace. That's a thoracic lumbosacral orthotic device that they're going to put them in. And again, the goal here is to keep them stable and keep them from flexing and extending and rotating. And again, keeping them from re-injuring this area allowing it to heal. Autonomic hyperreflexia, you might have heard it in the past called autonomic dysreflexia, same thing. They just always have to update fancy words, it seems, to make it more complicated for people. But so autonomic dysreflexia, autonomic hyperreflexia, same deal. What this is, it's a massive cardiovascular reaction that's stemmed by the sympathetic nervous system. It can occur after spinal shock resolves. It can be life-threatening, and you can read here the common causes: distended bladder or rectum, stimulation of skin or pain receptors. So if somebody is not, when I say somebody, if the nurse is not following a bowel program that the patient uses at home, let's say the significant other goes home, you've got this patient for 12 hours, during that time we should have done a bowel program, they become full of stool, this could potentiate this autonomic hyperreflexia. Forget to straight cath a patient. Again, that can trigger this response. So, signs and symptoms, hypertension. And when I say hypertension, I am talking through the roof hypertension. Their blood pressure can get as high, their systolic can get as high as 300. They can become tachycardic and then bradycardic as they digress, obviously. They could have diaphoresis above the level of injury. You might see facial flushing. Pale lower extremities below that level of injury. So something you really need to watch for. This can be very detrimental and life-threatening to a patient if it's not resolved. It could lead to having a seizure, it could lead to a stroke, heart attack, and ultimately death. Treatment, elevating that head of the bed, just as a real quick maneuver to bring down the blood pressure, but we're going to need more than that. We need to get to the root of the cause. So what caused this to happen? Have we straight cathed them? Do a bladder scan, see how full their bladder is. Maybe they need to have a Foley inserted. If we haven't removed any stool from them, we need to disimpact them. Maybe their clothing is too tight, you need to remove tight clothing. All of these things can help resolve this autonomic hyperreflexia. If those symptoms persist, they might need a vasodilator to help decrease that blood pressure. So a patient is going to go through a lot of rehab with a spinal cord injury, and we're going to talk about that in class. But anywhere from respiratory rehab, they're going to have bowel and bladder issues that are going to have to be dealt with. They might have spastic movement, spasticity, that is very bothersome to patients. And like I said, baclofen would be an answer for that, that they would take medication-wise. Definitely have to think about skin care. Because, of course, they're at great risk for pressure ulcers. Pain management is huge. Sexuality is going to be a huge change in these patients, right? So it is something that has to be addressed. And there are options. Your book, you can read about your book, there are options for patients to be able to resume, maybe not exactly how things went before the injury, but to help them continue on in relationships. Grief and depression is huge because this is life-changing for patients, and not just patients, but their families. So that is a big thing that you're going to have to deal with patients. Again, we'll talk about these things in class. And we said geriatric considerations, greater mortality because we have it combined with more of a chronic illness. And then this section of the chapter finishes off with talking about, or at least the spinal cord area of the chapter, talking about spinal cord tumors. Again, it's a small area of your chapter. I'm not going to have you focus a lot on that, but just note, obviously, that is something that patients can come in with. And a common symptom that they come in with is back pain. So tests are going to be done, CT scans, MRIs. If they see that that's a tumor, it can be outside the spinal cord, which is extradural, inside within the dura mater, but not in the cord, is that intradural extramedullary. And then within the spinal cord itself is intramedullary. So you can read through that and see the small section here that it talks about things that we really have to be thinking about. If you have a patient that's admitted with back pain, let's say, and they do a CAT scan and it shows that they have a tumor, and they're trying to treat them with drugs or determining if they need surgery. If in this process they would ever complain to you that they have numbness, they have tingling, they're not moving their extremities, of course depending on where that tumor is sitting. Let's say it's high up in the cervical area of a tumor. If they have respiratory complications, pulse ox is starting to drop. We really have to, that's a medical emergency in this patient's situation, because what's happening is what? They have a tumor, right? And whether it's outside the cord, inside the cord, no matter what, it's going to affect that cord itself. Even if it's outside the cord, the pressure of that tumor can be compressing the cord, and it acts like a spinal cord injury. So we go right back to that chart that I wanted you to look at of and the body systems that are affected. This patient can present or can look just like a spinal cord injury patient, and in the long run, if we don't do something about it, they're going to end up, that cord is going to be compressed, and they are going to have those effects that we would see in an actual spinal cord injury. So again, treatment's going to depend on where that's at and how what the surgeon feel the prognosis is. Sometimes it is surgery, sometimes it's medication, and sometimes it ends up being palliative care to help the patient live as comfortable as possible, because the patient might not be a surgical candidate. This concludes the spinal cord injury part of the chapter. It is really important that you guys read through this information, not just rely on what I'm telling you. In this lecture, I try to pull out highlights, but there are certain drugs and things that are talked about through the chapter, and hopefully this tries to bring the highlights at least to you, and then again, we'll apply things in class. So write down questions you might have that come to light as you're reading, and we can discuss those things in class. Thanks.